I'd like to thank the organizers for giving me this opportunity to run this molecular tumor board. Dr. Kruglianian's talk has made things much easier, so I won't be covering much of the theory which is already covered. And let's get back to some basic questions, especially related to our practice here. So I just want to know, so we can start from Dr. Bhavna Siroi because I think she has to leave early. Is genetic profiling or sequencing mandatory for every patient of breast cancer, or are there specific subgroups in whom it is indicated? And has this moved really from the research to practice? So that's what I want to know, because we have difficulties here, not so much the cost, because the cost has come down, but it is access to the drugs once you actually identified the target. So I just want to know your views, so we'll be quick about this.
So genetic profiling in my practice, and I'll talk about India as well, we should do after genetic counseling, I think, and we are extremely short of genetic counselors. So I tend to do it in patients who are less than 45 years of age, those who are triple negative, and with a strong family history. As far as mandatory sequencing, so I tend to do the usual ER/PR HER2, and only if a patient can afford alpelisib, or I would do PIK3CA mutation. Otherwise, in my practice, routinely I don't do it unless the patient can afford the drug, which again is very expensive in our setting. So routinely we don't do it.
So any of the medical oncologists would like to differ? Yeah.
So I possibly do the contrary of it. Sorry, but the thing is, it's not only about the drugs. It's about understanding the disease also. If majority of the metastatic hormone positive, if 40% will have a PIK3CA driven tumor, and if they have a dual PIK3, or if they have any other driver, it just helps me understand the disease better. And now with the AKT inhibitor coming up, I understand it's not there, but it takes me 3 months to request AstraZeneca to give me capivasertib. So why not have that 3-month advantage and keep at it with them, that if you can give it, rather give it than not give it. So what I'm saying is, it essentially helps me understand the disease better. So I do it for most of my patients. If there is even a slight hint that they are able to afford it, or if they can, which really is not a case anymore, I certainly do it.
Do you do it for the first time, or do it at the relapse?
So
For everybody?
for everybody, if they can do it, it just helps me understand the disease better.
At the beginning only?
At the beginning only.
Yeah, Dr. Shamagar
Yeah,
wants to say.
so I think with the availability of the PARP inhibitors, so you started looking at BRCA1 and BRCA2 for the adjuvant setting in the high risk, early breast cancer. Otherwise, I think the NGS and other things are done perhaps later on in metastatic disease.
I would now ask the molecular biologists that how many breast cancer specimens do they get, as opposed to the more common like lung and hepatobiliary now taking coming up this ladder.
Actually, there is a very latest ASCO guideline which is saying that you do germline BRCA testing for all patients who are less than 65 years. So that's for there. But besides that, that's just come, and what we have been doing, germline BRCA is there. Lot of germline BRCA testing. But if you ask me, compared to lung and cholangios, there are fewer comprehensive genomic profiling for breast cancer. It is there in triple negative, and especially in the metastatic setting, and even in HER2. And of course, PIK3CA we are seeing, and rarely ESR1 also. Yeah.
Yeah.
So in our particular settings, I believe that if the patient is ER/PR positive, we must go for a smaller panel, which include fewer genes like PIK3, TP53, ESR1. But if we are dealing with the triple negative breast cancers, metastatic setting, we should go for a comprehensive genomic profiling to understand better. But if I'm dealing with the family history of cancers, then additionally germline cancers testing is also mandatory.
Dr. Arun Kumar is from Foundation. So what is his?
So in fact, in our data, we see that there is, I would say, rank number 2 would go for, or rank number 3, the number of samples we get are breast cancers. maybe lung tops the chart, followed by GI malignancies, then breast cancer. And among the breast cancers, mostly it's after 1 or 2 lines of therapy who have progressed, and in a metastatic setting is what we generally get.
So I think that's what, yes, Dr. Goel.
So my question is that, for research purpose or understand a disease burden or status is okay, but the problem with the clinicians is that if you do it upfront and you find something, then how do you act upon it? Are you going to do the standard of care, which we're already going to do with the simple panel, or are you going to change the treatment? So I think that's where a lot of confusion happens, and to whether the whatever you find also is actually, taking the disease forward or not, we are not sure about that. So we are still a long way forward, I feel, in doing this test upfront.
So
And also most of the
Quickly,
most of the targets what even the professor alluded to in his talk has all come into the ER positive space, and we have well established therapies which have improved overall survival in first and second line, and also things like ESR mutation, it's dynamic. I mean, it changes with lines of treatment. So I don't see any point in sequencing an ER positive tumor upfront. Where we need to do it is maybe TNBC, but I don't see anything out in that space.
yes, Dr.
The one thing I would say is that I know we do the sequencing in TNBC because we don't have treatment options, but we don't find anything that helps us. So I would say that in some ways, if you didn't have a lot of money, you would spend it on HR positive disease where we can actually use the data to treat patients. Even somatic mutations, they happen more in lobular cancer, not so much in TNBC. And we don't know what to do with PIK3CA mutations, which we see in TNBC at all, because we don't have an approved therapy there. But I will say the only time where sequencing in the first line setting might make sense is based on a NAVA120, patients who have primary or secondary endocrine resistance, where maybe, I mean, who knows what the cost of that therapy will be, but, where triplet therapy could improve outcome and reverse resistance, at least temporarily.
Yeah. So now coming to the last question, because the other one has been answered. Would you go for tissue or liquid biopsy? Now, considering the actionable targets, so would you go for tissue or liquid biopsy? I would just like any of the one medical oncologist to take that question, and then.
Usually you would go for tissue biopsy. That's what preference would be. And normally tissue is easily available for breast cancer patients, So that would be the preference.
Yeah. But I feel like looking at the scenario, the best is you do both, okay? But it might make more sense to do a liquid biopsy first because of the dynamic things in ESR1.
Yeah.
The updated ASCO guidelines recommend indeed tissue if you're looking for IHC, right? But and that it's complementary, but the blood testing is so much easier when you're looking at a dynamic marker like ESR1, and it maybe give you a better view of the heterogeneity of the cancer. So
I think most of the hormone positives, when they progress, and if you're doing it in second line, they have bone disease, for which doing a tissue biopsy is so much more difficult. So I think if you're doing it in a second line, if you're trying to look for a ESR1, I think liquid makes so much more sense than having a solid one.
Yeah. So as Dr. Uprigo mentioned, that it's going more towards the liquid biopsy in these patients. So now coming to the case, this is a 62-year-old diagnosed with a left breast mass and backache in September of 2022. No comorbidities, in perfect health. IDC grade 3, ER strongly positive, PR weakly positive, HER2 news score 0 and KI 67 of 60%. Germline HBOC was negative. PET scan showed a multicentric left breast lesion with locoregional lymph nodes and multiple bone mets. Started on an AI and CDK4/6 inhibitor plus biphosphonates. The backache was relieved and there was clinical and radiological response for about a year. And then, of course, on a routine follow-up, the sonography was done. She was not symptomatic, but it showed that she had liver mets. And the rest of the disease, that was the bone and the lymph nodes as well as the primary tumor, were responding. So a repeat PET scan was done to see whether it is only the liver which was the site of progression, and it did show that the rest of it was responding except the liver. Now here, I want to know, what would you do? Would you do a biopsy here? Because everything is responding and the liver shows 3 lesions. So
Yes, I think I would do biopsy. Number one, to see if she has acquired HER2, and also to look for PIK3CA mutation. It can be done on the archival tissue as well as it was done in the trial, and then move forward.
Anyone else? Would you do a liquid biopsy or tissue biopsy?
Yeah.
More so to look at the ERPR HER2 more than anything. That's a differential. There's
The
so much
only
of
problem
differential
is-
response. You would want to know why there's a differential response.
The only problem is then it's ER negative, and then the patient doesn't
Possibly.
qualify for
Yeah,
any trials. I try hard to ignore it.
Yeah. Yes.
I just wanted to ask one question to Dr. Hope Rigo, now that she's here. Considering what is her opinion about the Sonia trial results, and do you still think that the upfront CDK plus AI should be given, or AI can be given first and CDK can be given later? It's not related to this. I just wanted to ask your opinion about that.
No, I think that, Sonia is like a trial that missed its prime. It was a very nicely designed trial, and I think important. But, now that if you have access to other therapies after first-line treatment, then you want to give the CDK4/6 inhibitor first. And I think there are some questions about the mutational profile and other issues about the patients in Sonia we don't know the answers to yet because it was only presented and it's not published yet. So I think it's important data if you have a patient with indolent disease and it's a resource stratification, you can give a CDK4/6 inhibitor in the second line because you're not going to have access to a lot of other things. And that's going to cost a lot less. But for patients where the cost is not an issue, I would give it in the first line setting.
Now, yes, please.
So just a comment, in case this biopsy turns out to be triple negative, so would you continue with the same treatment with the local therapy like an RFA, just because only there are 3 lesions, other lesions are responding?
We are coming to that. I'll just, yeah.
So also, I think I would add ctDNA as well to check for ESR1 mutation along with the liver biopsy.
So, the other thing that I was worried about is she's responding so well, and can there be something else in the liver? So that was the other reason, and sometimes that's why you have to resort to a tissue biopsy to make sure that you're dealing with the same disease. And as you can see that everything else responding and only the liver showing the progression. So now what is your next approach? So let's begin. Yes, please.
I had one patient where except for it was worse, diagnosed while in the first trimester of pregnancy. Actually, we terminated her pregnancy because she was 11 weeks pregnant and had widespread metastatic disease in bone, couldn't move, young woman, first pregnancy, and started her on ovarian suppression, letrozole, ribociclib, right? So at 6 months, everything is better, it looks fabulous, and she got an MRI of her breast 3 weeks later that showed a new liver lesion. So now it's like 6 months and a few weeks, and and then we repeated the scan, and her liver lesions were growing very rapidly, ER negative. But we put her on a trial because I made the point that there weren't enough cells, and we had a breast biopsy within 5 months that was ER positive. So we put her on she has a PIK3CA mutation, giredestrant, and inavolisib. And at the first scan, her liver lesions were almost gone. So, it's a question about what we see and what it really means when you get a biopsy. I'm like, why would that respond? Now, maybe inavolisib is enough, and the giredestrant isn't doing anything, but it's hard to know.
Yes.
Especially when it comes to liver metastasis in breast cancer cases, my experience personally is, at least in quite a few number of cases, the biology and the genomics is a bit different from the primary side. Especially the amplifications of certain parts of the chromosomes are very different, and they tend to respond to certain TKIs which was not in fact there in the primary tissue, those amplifications. So maybe we should evolve mechanisms to treat such liver metastasis separately based on the genomic profile.
Yeah. So we'll come back to the question of what would be your approach once we see the remaining. So the liver biopsy shows a metastatic primary breast. ER is moderate only in 15% of the cells. Remember, it was 80%. And PR is negative and the HER2 is negative, score 0. So would you do an NGS limited comprehensive liquid tissue was inadequate for a comprehensive genomic panel, and liquid biopsy was done. So, would you all agree with that?
My problem would be that you do not know whether the ctDNA or the CTCs, if you could isolate, they would represent the CTCs if you could isolate. The ctDNA, basically the ctDNA would be representative of the liver disease. I think that is my question to you. So I understand the tissue is inadequate, but when you picked up the blood, is it really representative of the tissue? But
Yes.
Actually, quite now a number of different studies, including by a former fellow of mine, where I wrote a commentary. But a number of studies since then that have looked at tissue and blood at the same time and showed that there's excellent correlation. And I mean, certainly our colleague can comment on that, but that there's actually you have a little bit more sensitivity for finding some mutations because again, sometimes the tissue there's just not enough there.
no, so we're talking about not the entire disease, but the new progressive disease in the liver. Will that be adequately represented in the so basically
well enough because the disease that's progressing is what's putting that DNA out into the blood.
Yeah, I feel tissue biopsy should be done because your HER2 state, all your status and everything will be required.
No, I think Dr. Hope has a point here that whatever disease is progressing, I mean, the cells, that they're going to shed the DNA, and which is what you're going to look at the liquid biopsy. And that is what you wish to target if there's an actionable mutation there.
So,
Will also be shedding.
yeah.
Can
So-
I just make a small comment?
Yeah.
So actually yesterday I was discussing with Dr. Hope Rugo and some other colleagues. We have a paper that's just about to come out in Cancer Research Communications, and we did repeated biopsies as well as liquid biopsies in patients with triple negative breast cancer who were progressing on treatment. And we found that the ctDNA actually captured all the mutations that were present in the tissue, but some additional mutations which were not captured in the tissue. And that paper is just about to come out. So, and the reason, of course, is that you have not been able to biopsy all the sites of metastatic progression, and essentially the blood is a sink where all those all the DNA actually goes.
Yeah, so that is the main reason why liquid biopsy would be more representative than just the tissue biopsy.
So I must also say that in our study, we sequenced the ctDNA at an average depth of 50,000x. And and that was ultra high depth sequencing for research purposes. But some mutations that are present at very low allele frequency will actually only be captured at such high depths. Now, whether they are clinically relevant or not is another question, but one does need to do the sequencing at sufficient depth.
I don't know if you could give us an insight into that paper. Most of the targetable mutations, what depth were they found at? I think that will possibly answer that.
So I also have to say that the corresponding whole exome sequence was at 200x, while the liquid biopsy was at 50,000x. And almost all the targetable mutations are captured at whole exome sequencing at 200x maybe. And when we say 200x, it's the average depth. Some parts of the genome are captured at 150x, others at 400x, but the average depth of 200x actually captured almost everything that was useful and targetable.
And sir, was the WBC is also sequenced to exclude the clonal hematopoiesis?
No. This was not
No,
WBC.
because when you're going to such a low depth, so you will have many mutations which have very low allele frequency, like 0.00, and your WBCs are also going to have shed mutations, which
So
is because
this was
of
not
aging.
from the WBC. What we did
Because
was we
how
took
you
care
know?
to actually exclude the genomic DNA, and it was only ctDNA. There was size criteria, but we also had buccal mucosa as the germline. And once you have buccal mucosa as the germline, then you can actually exclude what is germline. What you are saying is clonal hematopoiesis and shed
Exactly.
into the. Now that clonal hematopoiesis has very specific pattern, and the pattern that we found in the TNBC sequence was not that of clonal hematopoiesis.
So, Dr. Hope Rigo, I wanted to ask you, what about TMB? Because TMB is something where the neutrophils can contribute. So, how do you interpret a very high TMB on a liquid biopsy in breast cancer?
I think anywhere you're going to send a NGS2 in blood is going to be able to remove the neutrophils. So I don't think that's a really big issue. And, we don't see a lot of high TMB in breast cancer. We never see MSI. But,
So,
the TMB can be useful for using pembrolizumab alone. You only need it if you're going to be able to give pembro alone.
Yeah.
So.
Yeah. So then, of course, you can see over here that there was an ESR1 mutation, and it's the Y537S mutation. And also you have the PIK3CA, which was the H1047R mutation. So, going by these two mutations, as you know, that ESR1 Y57S mutation is considered a little less responsive to fulvestrant. And, you got fulvestrant both in the first option as well as the second option. So, you have the new drug, this oral SERD, being mentioned in the first option because they say that that may be more, this particular mutation of the ESR1 could be more amenable to the oral SERD. I'm always having a difficulty in pronouncing the name, LSS-stant. So, so I want to know now, suppose the drugs are available, all drugs are available. We don't have, I think here Dr. Hope Rigo can help us out, that in the BILEAV study, you looked at the cohort 2, and when there is a coexisting ESR1 mutation and a PIK3CA mutation, did you find a difference in the response or it overcame that?
No, we didn't. And it's an interesting question about whether or not you use ESR1 or PIK3CA here, but everybody is busy. Everybody who has an oral SERD is studying combination therapy now, and now that capivasertib is approved, everybody's buying or combining capi. So capi camizestrant, capi elacestrant will start in the next couple of months in our Elevate trial. Because obviously what we'd really like to do for a patient like this is combine an oral SERD or a SERCA or a PROTAC with a drug that inhibits the PI3 kinase pathway. I think that, if you had access to capivasertib, you would give that because I think you have less issue with hyperglycemia and other toxicities that are particularly hyperglycemia difficult in India in many patients. But otherwise, I think alpelisib and fulvestrant is what we would generally give in this situation if you could tolerate it. There is an oral PI3 kinase inhibitor from Lilly, Loxo, that is only for 1047R. So we would put the patient on a study with that drug. And then we have combination studies with oral SERDs and all of these inhibitors. So that's sort of the next step. It's just, we have a bunch everybody is doing these studies.
So that was I was coming to. So if the TMB being high, so can it be a signature for ApoBec? With the MSI stable, TMB high, PIK3C mutation, can it be a ApoBec signature which possibly there might be some benefit of if in this line immune checkpoint or later on?
Yeah, I mean the question is you can get since there's agnostic approval in the U.S. for Pembro in this setting, you can get Pembro, but if you combine it with something else, the insurers say no. So then usually what I have to do is give something and then get expanded access Pembro, which is kind of ridiculous because it is approved in that setting. Because I think most of us are reasonably uncomfortable giving Pembro alone in that setting in breast cancer because maybe the responses are kind of on the low side for what we want to see.
Would you ever combine let's say, but for the LSS trend, there are 2-3 questions which I wanted to ask. For LSS trend, if the PFS with the AI CDK has been somewhere around 12-13 months, would you choose ESR1 over PIK3CA or would you choose PIK3CA over ESR1?
It's really hard. I think a lot of people answer elacestrant first and see if they respond because the toxicity is so much less. But in a patient who's having progressive liver mets, I might choose the combination therapy. Just because of the issue with the liver mets generally being a sign of endocrine resistance moving forward. Now, elacestrant worked equally well in patients with liver mets, and she had a long duration of, how long was her duration?
13 months.
Yeah, so that was pretty
months.
good for a response to elacestrant. And if you watch carefully, you can always try it and just watch the patient carefully and see if they get a response, and then go on to alpelisib fulvestrant.
And if I give you AKT inhibitor along with this, so let's say capivasertib is also one of the options.
Then I would use capi instead of alpelisib.
Okay. So, and the second question is, which I wanted to ask you is, with
And then I give
TMB of
Pembro next.
yeah. So would you bring in Apobec here, or does it never?
No, I mean, I think with a high TMB, it gives you another treatment option for this patient if you can get Pembro. So I would give it, but I would give it after these therapies because, you know, in general, if a patient's endocrine sensitive disease, I'm going to give the checkpoint inhibitor later. I did have a patient with lobular cancer, you know, presented with metastatic disease, de novo, with bowel obstruction, you know, functional bowel obstruction, terrible case, and responded to, had an RB loss. Didn't have any response to CDK4/6 inhibitor. We found this RB loss, and then went on and got liposomal doxorubicin and responded for 3 cycles, progressed and didn't respond to anything else. Was on TPN at home, and the patient's daughter said to me, should you try that immune checkpoint inhibitor just to see? Because now she's on TPN, right? So I put her on, there was nothing to biopsy because she had diffuse disease in her abdomen. So I put her on capecitabine and pembrolizumab, and her disease went away for 3 years. It was the most remarkable thing. And when we finally were able to biopsy her growing disease, her TMB was 50.
I just want to add one thing. I think this is from the garden, and here the cutoffs, what I remember, is different from different types of tumor. So probably it's 24 or 27 mutations per MB. So this may not be high, but otherwise, considering for this garden, garden. This is a garden report.
They just tell you that 20.7.
No, but there is some disclaimer written down that this for this particular thing. So it is for the breast cancer especially, it is much higher. So but the approval, FDA approval is 10.
No, I'll just make a point here. In a pure molecular point of view, what we are missing here is the BRAF mutation. Now, if you see the ESR1, the allele fraction is 0.02 percentage. Oh, sorry. Yeah, the ESR1 has a variant allele fraction of just 0.02 percentage, whereas the BRAF has as high as 0.3 percentage. Now, this is a activating mutation. Now, my point is, irrespective of how we are going to target the PIK3 or the ER pathway, there is going to be a progression because the alternate pathway through the BRAF is activated. Now, second point definitely is about the TMB. As Dr. Moshmi rightly suggested, different panels have different cutoff values. Now, the cutoff value of 10 was made based on Foundation Medicine's solid tumor testing. Same Foundation Medicine's liquid, the cutoff is 16. And for Guardant, it is a different cutoff because the panel size varies. So you cannot have a uniform cutoff for interpreting the tumor mutation burden.
Yeah. So, yeah.
I think the BRAF also, this is not the conventional.
It's not the conventional,
yeah,
but it
BRAF
is a gain of function
1,
mutation.
2, 3 mutations. So this probably, even for lung or other cancer, we don't have drugs.
Yes, we don't have drugs for this
for it, but
BRAF.
I'm saying it's a kind of a resistance mechanism.
Yeah.
And it's not classified as a variant of uncertain significance.
Yeah. So, I just want to find out whether, given this, sometimes availability of drugs, what is your experience with changing the endocrine backbone and continuing the CDK4/6 inhibitor, maybe a different one? There are 3 trials in progress. What do you have to say, Dr. Hope, on that?
In this patient, I wouldn't do that.
Yes.
I think that, she's already demonstrated a reasonably short PFS on CDK4/6 inhibitor. I think the patients who have, like a single progression, a single bone lesion, and they don't have any mutations and they have very indolent disease, that's a situation where we might think about it.
Okay, sure. So, patient is on alpelisib and fulvestrant and is responding. That's one of the reasons being we don't have the oral SERD available to us. The only thing about the oral SERD in the intention to treat population, the actually PFS benefit over the treatment of choice was just 2 months. And it was only in the ESR1 mutated population that it was a little bigger, the gap was a bit bigger. So what do you have to say?
It was also bigger in the patients who had a very good response to AICDK.
Yes.
So if you look at the subset, if I remember correctly, anybody who responded more than 6 months, I think it was 6 months subset, they had a very good response to oral elacestrant. So I think when they have splitted the entire thing, L-assistant would be a good choice here if it is available.
Yeah, and it's interesting, if you look at the curves for Emerald, 40% of the patients progress by their first scan, which I think, shows us that we're really crummy at differentiating endocrine sensitivity when patients progress. And that's why we actually recommended that they look at the duration of CDK4/6 inhibitor therapy as a surrogate marker of endocrine sensitivity, which is exactly what you mentioned. And that's one way to try and choose which patient is more likely to benefit.
So, these are the genomic alterations, and we've, Dr. Kruguliano has also mentioned all these, so I won't go into that. One important thing to remember, and that is, if this patient were one of the mechanisms of resistance is the BRCA1 mutated patients having a lower PFS and overall survival on this combination. So, Dr. Hope, what do you want to say about this? The germline mutations having a worse outcome on this dual hormonal.
Yeah, there's now, as you pointed out here nicely, quite a number of different series that have suggested this. I think, it's all looking at patients who may have other reasons to cause their shorter PFS, but you just don't know. And I think we're still using CDK4/6 inhibitors first, but second line in that patient using a PARP inhibitor.
So this is just, the editorial on the Emerald study, and they've actually tried to highlight the patient who is with ESR1 mutant PIK3CA and PIK3CA wild type advanced breast cancer, maybe one of the best patients for this, and with a long control on the first line therapy. So the treatment algorithm, and I think Dr. Hope Rugo also put it in the SABCS 2022, that depending on the mutations, you can, then go ahead. And then, of course, last but not the least, if you have a low HER2 positive, then you have the Durexistican or even sacituzumab. So, and if you have a germline BRCA, you can use it anywhere from first to third line. So, now the case 2, this is a same type of patient, and I was surprised to see that in a year I got 2 patients of the same type, that this patient had a actual PFS of only just 4 months. So, this is like a primary endocrine resistance. So, is there, and this was the NGS report that T53 was of VAF 44.56% and CCNE1 was amplified. So, I want to know from the molecular biologist, can this report miss RB1 alteration?
Quite possible. We have to see whether first if it was a small or a larger panel. And if it was a larger panel, we should see, because there is a possibility, because CCNE1 amplification is a resistance mechanism for CDK4/6 inhibitors, although that is not generally a primary resistance mechanism. It generally evolves over time. So if there is just a 4-month PFS, I think there should be some primary resistance which needs to be analyzed.
Yeah. So, this patient, what would you do? Like, what would be your next line? It doesn't have ESR1, there's no PIK3CA, and it's a 4 months, and you can see the liver biopsies, ER 20%, PR negative, HER2 +1, and the fish is negative. So, obviously, in the liver, it's a low HER2 expressing tumor. So, of course, now I want to know from the pathologist, what is the correlation of NGS, ERB, copy number, and the IHC? Because there can be, now with the low HER2 expressing tumors, there can be a lot of variation, interpathologist variation in that 0, 1 and 2, maybe 0 and 1 definitely. So, will NGS really help here?
Actually, no. Because look, what you are doing on IHCs, you are manually seeing the areas which are stained more and then grading it. If you have a smaller area, maybe more than 10%, and then you are grading it. But what you do on NGS, how you calculate the copy number is you are taking sort of an average and creating a log value. So it may not be, in fact, the lower values may not be picked up that well on NGS compared to what it is seen on the manually or by a pathologist.
Yeah.
So it's not.
So IHC, when we say +1, it is less than 10% of the membranous staining, which is low, which is weak. So when we look at NGS, we need to look into ERB2 amplification, and we have a different cutoffs for different pipelines. And when in our pipeline, we have a cutoff of 6 and more. So probably, even if I get 1 or 2, I will not be reporting. So it does not actually correlates.
So, Dr. Opryugo, there was a publication which has looked at, the NGS in HER2 low. And what they suggested that the correlation was better with the 2007 ASCO-CAP guidelines rather than the recent one. So, is there something like that happening in the US? Like, what is the discrepancy rate between pathologists, and how do you do the trials in
We
HER2
talked
low?
about this some at the earlier panel, but I think that in general, the correlation, at least for the trial, was very good with local and central testing. And I think because we believe that TDXT is likely to work even in patients who have slightly less than 1+, if you have any positivity, I think at any time, we generally figure that's rationale for giving TDXT. For patients who are persistently 0, it's hard to know whether or not what the correlation is there. I think we need a little bit more information. We know that ERB2 copy number is higher in ER positive than ER negative disease. This case, this is a patient who's losing ER rapidly, and these patients tend to have disease that behaves more like triple negative breast cancer in my experience. And so, we don't have TDXT in the first line chemo setting approved, so you'd still maybe start with capecitabine, but, I would give one more, if her liver was okay, I would give one more attempt at endocrine therapy before I gave up, because you're not going to go back to it.
So that was my question. Would you choose a fulvestrant over capecitabine in this patient?
Fulvestrant plus.
Fulvestrant plus, continue the CDK for?
Everolimus, she already progressed in too short a time.
Would you think there is, because it's possibly behaving as a functionally triple negative, would you think there is any role of a PDL1 here?
For a PD-L1, well, it's an interesting question, what works in ER positive disease in the metastatic setting, and because of the impact of PD-L1 positivity in the neoadjuvant setting in both Checkmate 7FL and the Keynote 756, I think that it's likely we'd only see impact in patients who have PD-L1 positive disease. So as she continues to lose ER and goes to chemo, I would definitely check for PD-L1.
So because in the 756, the patients who had low ER had a very good response to the neoadjuvant, and that's
but that was less than 10%.
Yeah, so that,
But patients, the response, the benefit of Pembro increased sort of almost linearly with the PD-L1 expression. So, and I think that was true in both studies. So it suggests that in this patient population, PD-L1 expression is important.
So, we've covered all this. So I think the toss-up was between fulvestrant and whether you'd go for Durexistican. That's the thing. And then, of course, we come to this systemic therapy in this NCCN guidelines. In the second line, you can see that IHC 1+2, this Durexistican is category 1, and sacituzumab comes much lower in these patients. So this is your slide from SABCS 22, and it really shows how you can, sequence therapy in HR positive, HER2 negative metastatic breast cancer. Now the last case, and I think, how much time do I have? Yeah, so this is a short case. 45-year-old TNBC in Jan 21 received chemo, surgery, residual disease, received capecitabine. 2022 May, presents with pulmonary mets. Biopsy shows TNBC. CPS score is 4. The germline mutation is negative. And NGS on the tumor is somatic mutation BRCA positive. And the TMB is 12 mutations per MB. So now I would like to know that how would you sequence these drugs?
So if we look at the CPS scoring here, it's again borderline. It's 4. So above 5 is something significant.
No, but in the studies it has to be more than 10.
CPS, yes. So and even in the TMB, it is again
It's 10 for
10.
the pembrolizumab
Yes, it's
study,
10.
and this is 12.
And if we look at the germline mutation, which is negative, and we have a somatic mutation, so we need to look into the VAF, whether it is heterozygous or not, and we need to look into the family history, of course, which is negative. But the somatic mutation could be a possibility that we can combine the olaparib and pembro is something we can look into.
So, no, before you combine, sorry for interrupt, before you combine olaparib with pembro, why not use pembro, just use it till the end and then give olaparib? So what I'm coming at to is, let me be a little more specific. You start with the gemcitabine cisplatin Keytruda, that's the approved indication for the thing. You consume the gemcis and then you continue Keytruda till the time there is a disease progression. Whenever there is a disease progression, you probably would have enough platinum-free time and then use olaparib.
Yes.
I would say,
But the
we looked at, the only thing we looked at in Keylink 009, we presented at San Antonio was, people got that induction, and then they were randomized to either get pembro and olaparib or continued chemo and pembro, but most of the people ended up stopping their chemo eventually anyway. But we don't have all of those detailed data, but people who had tumor BRCA mutations, and we don't know yet how many were germline and how many somatic, which is ridiculous, but someday we will when Merck tells us. But, because they're not pursuing that forward, they're not pushing those studies either. But those patients who had tumor BRCA seem to do much better with that combination than with continued chemo and pembro. So, I do think there's some rationale for it. The sequencing is important, and we don't know how much benefit that would be, so you make a really important point. But there's something appealing about that combination because of the preclinical data suggesting upregulation of the STING pathway, which I think is kind of a cool idea too.
So would doing a HRD score be helpful in such a scenario? It's because it's somatic positive.
No, Dr. Hope, the study which you're quoting, I think it was a negative study in olaparib pembro versus pembro chemo. So it was statistically significant.
No, but the study, that's not what I'm mentioning. So the study was done in all comers. The issue was, does olaparib pembro result in a better PFS than continuing chemo? And it was the same, which means you could stop chemo and just give pembro and you'd be okay. But in the patient population who had tumor BRCA, it was better.
But it was not statistically significant.
Well, but the trial wasn't powered to look at that. It's a small population, but it was really a lot better.
Yeah, I know.
Just a point here. When we are dealing with somatic BRCA, we have to be a bit careful because for the BRCA to become be it platinum or PARP inhibitor sensitive, there should be a biallelic loss. So most of the somatic BRCAs are events which need not lead to a biallelic loss. That is, both the copies of the gene should have a loss. Now, it's very imperative to check the HRD before going on to olaparib therapy, or at least look into the platinum sensitivity.
We didn't see that in the olaparib expanded trial that Nadine Tung published. We participated in through our consortium in their ongoing accrual now to an expanded study. But patients who had somatic mutations had a very good response to olaparib.
What was their germline status? But the germline status
was wild type.
No, it was patient who had, as it rightly said, the patient who had somatic BRCA also, they had benefit from olaparib. That's what it is.
In fact,
I've seen that in clinical practice. We don't check HRD usually.
Their HRD may be high, because possible. So that's what I said. There may be a role of looking at HRD score because whom to give and whom not to give.
Because in the study, the somatic mutation response rate was almost 60%. So, yeah. So I think we come to the end of this molecular tumor board, and I'd like to thank the panelists and also the audience for their interactions. Thank you.